The purpose of this video is to present a novel application of negative pressure wound therapy, which is the application of suction to a wound surface for potentially helping with the treatment of periodontal disease. As an orthopedic surgeon, I have used negative pressure wound therapy extensively in wounds of the spine and the extremities and have found it to be very effective in salvaging situations where few other options have existed. I wanted to see if some of the successes I've had with negative pressure wound therapy would be applicable to address some of the frustrations I've had personally as a patient with periodontal disease. We will be looking at the use of an oral appliance for application of negative pressure wound therapy to the soft tissues of the mouth. This presentation will be divided into 5 separate sections. First, we will discuss the benefits of negative pressure wound therapy. We will go over details of periodontal disease and how negative pressure wound therapy could be beneficial in the mouth. We will go over some of the mechanics and logistics of how this pressure could be applied, and I will give my conclusions. To understand the potential benefits of using negative pressure wound therapy in the oral cavity, we must first take a minute to examine how negative pressure can help heal wounds in more challenging situations. The majority of wounds go through a series of phases and heal uneventfully, but in cases where the factors favoring and against wound healing are in a balance, kind of like a tug of war, a chronic wound persists. To disrupt the chronic wound state, some change has to be introduced into the system, which usually involves some sort of debridement to remove non-viable tissue and stir up an inflammatory healing response. Negative pressure wound therapy can help tip the scales in favor of healing. The key component is vascularity. If there is adequate circulation, wounds will heal. As any guy who has cut his face shaving can attest, heals in 3 days. Similarly, no ancillary treatment, negative pressure or any other, will induce healing if there is not adequate blood flow. Negative pressure helps promote healing with both macro and micro effects. Reduction of tissue swelling lowers interstitial pressure and improves local blood flow. Negative pressure contracts the wound edges, leaving less surface area to heal. However, the micro effects are more profound. In response to negative pressure, focal tissue strain causes ingrowth of healing cells called granulation tissue, and this healing tissue has a rich microcirculation as new vessels are formed. While looking at these two wounds might not seem like an apples-to-apples comparison, in both situations, decreased swelling, wound contraction, and augmentation of vascularity is clearly advantageous. Even though negative pressure in the extremities usually takes weeks to be effective, the fact that for my own periodontal surgery where the dressings and sutures started falling out after 3 to 4 days with healing evident indicates that negative pressure wound therapy may have a role in treating periodontal disease. The hallmark of periodontal disease is the formation of pockets at the interface between the teeth and gums. Why this condition develops may be a chicken or egg question, as there are multiple risk factors, but as the pockets get deeper, patients are at risk of multiple symptoms as well as tooth loss. Normal anatomy is notable for pockets being between 1 and 3 millimeters, and the tooth is firmly anchored to the bone. In early periodontal disease, gum swelling occurs in reaction to the film of bacteria called plaque that forms on the teeth, and pockets deepen to more than 3 millimeters. As a result of the inflammation, bone starts to recede from the teeth, making them less stable. Moderate periodontitis, which is really a chronic wound, can be characterized by the formation of tartar around the neck of the teeth. In reaction to chronic inflammation, further bone loss can occur by similar cellular mechanisms as when an artificial hip joint gets loose from the inflammatory reaction to wear debris. In more advanced cases, bone resorption becomes more severe, causing teeth to become loose. It is this bone loss and not tooth decay that is the most common reason people lose their teeth. The factors leading to pocket formation become self-perpetuating as illustrated by this vicious circle diagram. The formation of plaque leads to inflammation and swelling, which results in focal immune dysfunction and subsequent destruction of tissues anchoring the teeth. Bone resorption occurs, and as a result, more places are created for bacteria to hide. Although most diagrams show these pockets to look wide open, in reality these pockets are like the lining of your pants pocket, where it's collapsed until something is put in it, in this case, a periodontal probe. An important detail is that, absent professional care, patients cannot clean the pockets of bacteria below a certain depth, even with regular use of ultrasonic toothbrush, flossing, and pulse lavage. The depth of the pocket remains a place where bacteria can reside on a chronic basis. Negative pressure can be an additional tool for the treatment of periodontal disease. Due to the fact that it takes a long time for pockets to form, these pockets often become lined with epithelial cells, which are a specialized cell type that often acts as a barrier. These cells act as a covering or lining for body surfaces, like skin and the digestive and respiratory tracts, among other locations. Unlike the types of cells in an acute wound which generally heals, epithelial cells are specialized to maintain the separation and often have little biologic activity. The cells closest to the surface, which are sloughed off to maintain the barrier, are often non-viable. This characteristic of epithelial cells can be illustrated by the fact that one cannot heal two fingers into one by holding them close together or even by applying a wound vac. Since the lining of the pockets often includes oral epithelial cells, the following point is critical. To tip the balance towards healing, the plaque and tartar would have to be removed from the tooth root, but also the epithelial layer would have to be disrupted in order to engender a healing response. Negative pressure could have a positive effect at this point. As will be outlined in the next section, negative pressure could be applied with use of an oral appliance with multiple benefits, including removal of tissue fluids and residual bacteria, creating a gradient to bring in new healing cells and vascularity, and wound contraction would occur. The net result would be reattachment of the soft tissue to the tooth root, possibly with reformation of some of the periodontal ligament structures. While the goal of home care is to interrupt the vicious circle by decreasing bacterial load, negative pressure wound therapy could provide additional benefit by making pockets more shallow, leaving less surface area for plaque to form. Also to be determined is whether, using the same benefits as outlined previously, negative pressure could augment healing of other wounds in the mouth. There are aspects of the anatomy of the oral cavity that make negative pressure easy to apply compared with the trunk and extremities, which is fortunate since a vacuum sponge in the mouth would likely be poorly tolerated. While the sponge is essential in the extremities and trunk for even distribution of negative pressure to the wound surface, the sponge would not be necessary in the mouth. The spaces between the teeth allow for equilibration of the negative pressure to the soft tissues covered by the oral appliance. While the adhesive dressing is a key factor for maintenance of the negative pressure environment in the extremities and trunk, no such adhesive would be needed in the mouth. Due to a combination of the flexibility of the oral appliance and the fact that the mucosa is naturally moist, a seal can be easily created without any adhesive agents. Negative pressure would keep the appliance in place. To understand more about focal application of negative pressure, we can look at how the prototype oral appliance was fabricated. A common procedure for dental professionals is to make an impression of the patient's dentition, from which a positive model can be made of the patient's specific anatomy. As is done in the making of bleaching trays or bite guards, the oral appliance is made using a vacuum formation technique. However, during the fabrication process, channels can be created where negative pressure is to be applied, which in most cases would be at the margin of the tooth and gum, known as the gingival sulcus. This channel could be created by applying some putty or a similar material to help focus the negative pressure on this area on the dental model before the vacuform process. With negative pressure applied, the appliance would have contact with the teeth and with the soft tissue areas indicated here in pink for this upper arch model, with negative pressure focused on the periodontal pockets. These channels could certainly be modified to direct the negative pressure to other desired locations in the oral cavity. To attach the suction tube, additional space was created at the anterior aspect of the appliance by gluing a button to the front of the dental impression before the vacuform process. A surgical drain connector was modified to allow for attachment of the suction tube. Although negative pressure treatment in the trunk and extremities requires pressures in the range of negative 125 millimeters of mercury, lower pressures would be required in the mouth. To meet this need, although such use would be considered off-label, there is a currently available portable device that is battery operated and generates negative 80 millimeters of mercury pressure for 7 days. While other possibilities for generation of negative pressure could even be the use of currently available surgical drains, given the excellent healing potential of tissues in the mouth as compared to the extremities, a 7-day course of negative pressure would likely be more than enough. Following debridement of the pockets, the appliance could be worn for application of negative pressure for 12 hours or more for probably under a week for optimal effect. I can also attest from personal experience that the appliance was not uncomfortable and I was able to sleep with it in place. This project, which hopefully is a favorable example of thinking outside the box, is an attempt to add a new treatment strategy to a common problem. We have reviewed the advantages that negative pressure wound therapy can provide to influence the healing process as noted here, including providing a moist, closed environment for wound healing, macro strain drawing the wound edges together, reduction of tissue edema removing infectious material, promotion of perfusion or ingrowth of blood vessels, and microstrain on the tissues which promotes granulation tissue and cell migration and proliferation. We have reviewed how a prototype oral appliance was able to comfortably apply negative pressure to the gingival tissues. As part of my research, I have come across other potential treatments. One treatment plan involved putting an antibiotic gel at the gingival sulcus with a type of tray appliance, but I have a hard time seeing how the medication will get to the depth of the periodontal pocket any more than putting antibiotic ointment on a puncture wound would get to the deepest part of that wound. I noted another technique involving use of a laser to kill germs and remove non-viable tissue and activate adjacent soft tissue to reattach. Assuming this technique works as presented, given that a pocket is still left after that treatment, it still seems like there would be a race between the cells lining the surface becoming non-viable with pocket reformation versus healing of the soft tissue to the tooth root. If the laser works as outlined, negative pressure wound therapy could be an important augmentation to that treatment plan. The fact is, periodontal pocket formation is very common. According to a 2012 publication from the American Academy of Periodontology, half of American adults suffer from gum disease. Therefore, a technique that is simple, comfortable, patient-friendly, and used only for a short period of time could represent a possible paradigm shift among the treatment options and also possibly a huge market opportunity. Thank you for watching this video.